So welcome everyone. Thank you for joining AMETHIST Penn's December 2025 monthly seminar. We're proud to offer this content through our AMETHIST Penn Hub, which stands for Achieving Maternal Empowerment and Transforming Health Through Implementation, Science, and Training. Funding for this hub comes from the NIH's Improve initiative, which aims to reduce maternal mortality and improve pregnancy, perinatal, and postpartum care. As a reminder, we will be recording this discussion. It'll be available on our YouTube channel after this session. Please feel free to put any questions in the chat throughout. We will also have time for some additional questions at the end. This month, we are very fortunate to have Dr. Katelin Hoskins here with us today to speak about thorny ethical issues in implementation research. Katelin Hoskins is an assistant professor in the Department of Biobehavioral Health Sciences in the School of Nursing and is a senior fellow at both the Penn Implementation Science Center and the Leonard Davis Institute of Health Economics. So we are very fortunate to have her with us here today. And with that, Katie, I'll turn it over to you.
Thank you so much for the invitation. I'm just thrilled to be here and really excited to talk with you about this topic. I have done some graduate work in bioethics, and since coming into implementation science, have just been fascinated by the ethical issues, which are often subtle, that can come up in implementation research. So looking forward to taking a dive into that with you today. I'm also really thrilled to be part of Amethyst as a co-investigator in our equity core. I just want to note that I don't have any conflicts of interest to disclose for the talk today. Just as a note, I can't see the chat, but feel free to drop any questions in there and we can come back to them at the end. And then anything I don't address, I'm very happy to get back to folks on or continue the conversation by email at any point in the next couple weeks. So just in terms of the agenda for what I'm aiming to cover today, I'm going to talk a little bit about why implementation research ethics are distinct, why we're operating with a different paradigm, kind of thinking about, are we doing research? And if so, who are our research participants or our subjects? What about informed consent? I'm really interested in cluster RCTs, which we do a lot of work within implementation research because they raise interesting questions related to gatekeepers and vulnerable populations. And then I have a brief use case that pulls directly from an IRB protocol from an R01 that I'm leading that gets into issues around waivers of informed consent and the criteria for that we can walk through together. So jumping in today, I want to first kick off our conversation in terms of thinking about why implementation research ethics are distinct. And just to level set for the group, and always going to start with reorienting to us to what implementation science is. One leading definition is that implementation science is the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings. And so another way to frame this is that implementation science seeks to improve the adoption, adaptation, delivery, and sustainment of evidence-based interventions in healthcare. And central to this goal is understanding how interventions are delivered effectively in context. And so we've spent over 15 years wrestling with some complexities related to implementation research from both an ethics and a regulatory perspective. First of all, implementation research spans both clinical as well as social behavioral research. And notably, social and behavioral research studies have risks that are variable and more difficult to predict, though often considered no greater than minimal risk. Often our work has multi-level intervention targets. Our work often focuses on systems, organizations, and unit-level processes, plus individuals who might be patients and or clinicians or employees. Much of our interventions are on clusters, and as I mentioned, we'll talk about this more specifically toward the end of the presentation. We have incomplete guidance on how to define risk based on study design, particularly in late-stage translational research. And we have varied and complex study designs. And so in implementation research, we use lots of different study types and designs. Research designed to evaluate the impact of context inevitably takes on many forms, and design selection is really critical to capturing data in a manner that appropriately addresses your research question. So just to highlight, RCTs are types of experimental clinical studies where participants are randomly selected into either the intervention or comparison group and then followed over time. And Back to thinking about our evidence hierarchies, well-conducted RCTs are often considered optimal or kind of quote-unquote gold standard in offering a fair test of effectiveness by balancing confounders so that differences in outcomes between comparison groups can be attributed to intervention effects. We also do a lot of work with quasi-experimental designs, which encompass a broad range of non-randomized intervention studies, like interrupted time series, and are frequently used when it's not logistically or ethically feasible to conduct an RCT. And then we loved mixed methods in implementation science, which combine at least one quantitative research method and at least one qualitative research method into a single study design. And as an extension of qualitative methods, our work often uses community engaged approaches like CBPR, which have their own ethical considerations, and happy to talk about those in more detail in another talk as well, because there's certainly many facets to explore in that domain. Bringing us to our implementation research subway and reorienting us to the realm of studies here, we've got two branches off the subway line that are of particular relevance. Often the world of hybrid effectiveness implementation trials, where your intervention of interest has either no or partial effectiveness, and then squarely in the world of straight up implementation research, when you have an established evidence-based intervention and are looking to conduct either mixed method studies to understand context, you're designing implementation strategies, or you're testing strategies head-to-head in an implementation trial. And I think hybrid trials are just so fascinating because they add even more complexity when we combine effectiveness and implementation research. Importantly, hybrid type 1 and type 2 are not just about establishing or scaling up an established EBP. Particularly in type 2s, we're studying both the intervention and our implementation strategies. And I just want to highlight as scaffolding for this conversation today, and as a reminder, implementation strategies are our interventions in implementation science. Those are the strategies that we're using to drive behavior change. And so for lots of details beyond the scope of today, I'd strongly encourage you to check out this supplemental, this article here from Wolfenden and colleagues. It's a really great resource if you're embarking on implementation study designs. And I bring that up now because design matters so much for our ethics. Of note, there are no ethical frameworks specific to implementation research. We draw on specific frameworks for medical ethics, clinical bioethics, also known as clinical bioethics, research ethics, and public health ethics. And so medical ethics really focuses on individual patients, doctor-patient relationships, and the duties of doctors and nurses historically. In research ethics, the focus is on protection of study participants, informed consent, risk-benefit analysis, equitable subject selection, and access. And then in public health ethics, we focus on population health, health policy programs and policy issues, scientific evidence, public participation, and preventive measures. And so we can really think about implementation research ethics as sitting at the intersection of these three different frameworks. What's important to acknowledge is that implementation science is a different research paradigm than traditional biomedical research, because the focus of the work extends beyond discovering what works to ensuring that it works in practice within complex systems. And so frameworks for medical ethics, research ethics, and public health ethics have to be interpreted and then applied, which requires a lot of synthesis depending on the particular study, the design, and the setting, like if you're doing hospital versus policy implementation. And important to note is that implementation science doesn't require new ethical principles, but it does require attention to context. This is what we keep coming back to. Because implementation studies typically evaluate interventions whose benefits are known to outweigh their risks, there's key considerations related to beneficence and justice, since disadvantaged groups may stand to especially benefit from adoption of research innovations. As another feature of context, patients, clinicians, healthcare administrators, and health policymakers are all participants in the healthcare system, and they have a shared interest in optimizing how the system functions to improve health. And so here, these constituents have a special reason or even perhaps a responsibility to participate in improving the system through implementation research. And so I'll point you to this figure from a paper from Gopachandran and colleagues. This was published in 2016 and was one of the very first papers that explicitly discussed the ethics of implementation research in health. The authors do just a fantastic job at identifying ethical issues specific to each phase of implementation research, from the planning phase to the implementation phase and the post-research phase. And if you take my class, Implementation 6100, Ethics and Equity in Implementation Science, next offered fall 2026, we'll talk about all of these things. But today I really want to hone in on the planning phase, really kind of thinking through these questions, which are critical kind of upfront planning of your work. Is it human subjects research? Whom is a participant or subject for each activity? What's the risk of each activity? And is informed consent required? And if so, by whom and for what? And so I'll flag these two papers here that I rely heavily on. The first is Developing Ethical Standards for Dissemination and Implementation Research, a roadmap for consensus and guidance. This was published recently in Implementation Science Communications. And then we'll highlight a paper that was also just published a few months ago, Ethical Issues in Implementation Science, which highlights perspectives and kind of consensus report from an NHLBI Institute workshop, one of the first of its kind to focus on ethical issues in this very unique space. So let's talk about is kind of what we're doing is our thing, our questions that we're asking, is it research? Which requires us to kind of define and get really clear on what exactly is research. As some historical context, in the wake of usually horrific research scandals, including but not limited to the Tuskegee syphilis study, the Willowbrook hepatitis experiments, and the Jewish chronic disease hospital study, public consensus emerged in the 1970s that research primarily serves the interest of science and of future patients rather than the interests of patients at hand. Research is therefore prone in ways that clinical care is not to exploit patients or expose them to unjustified harms. Traditional mechanisms for protecting patient welfare, like reliance on professional integrity and physician licensing, were judged to be clearly insufficient to safeguard the interests of patient subjects in light of these tremendous harms that were enacted. And so in the 70s were sweeping policy changes, including the federal requirements that most human research be overseen by a system that included review prior to the conduct of the research, with an institutional review board, an IRB, charged with ensuring that the research has a favorable risk-benefit balance, an adequate consent process, and a fair system of selecting subjects. There was the demand for impartial third-party oversight of research, though interestingly, like nothing comparable for clinical care where there's also risks and notable burdens. But this all led to the Belmont Report in 1978 and also generated what's been called the research practice segregation model, which made clear distinctions at the time between research and kind of practice therapy clinical care. A key contribution of the Belmont Report was identification of three key principles: respect for persons, which generally requires informed consent and provides additional protections when participants are incapable of providing informed consent; beneficence, which focuses on minimizing the harms of research, establishing appropriate protections, and ensuring that anticipated benefits justify whatever risks might be involved; and then justice, which establishes that populations that undertake risks in research should also be beneficiaries of that research. The US federal regulations define research as a systematic investigation, including research development, testing, and evaluation, designed to develop or contribute to generalizable knowledge. So there's two key defining features here in this definition. The first being requires a systematic investigation or systematic collection of data, which is in contrast to the more like traditional idea of practice in which there's not systematic data collection. And then it's designed to develop generalizable knowledge. So here, generalizable knowledge means that information, findings, or conclusions are intended to apply beyond the specific people, places, or situations being studied. In other words, it's knowledge that can be used to draw conclusions or make predictions about a broader population, not just to understand one specific case or local situation. And so this also contrasts traditional ideas of practice where the intent is to help the patient in front of you at hand. I'll note these distinctions quickly get conceptually messy in modern healthcare. Remember, this was developed in the 70s. We're 50 years out now, which in the work we do in modern healthcare involves constant data collection, analysis, and improvement. In learning health systems in particular, practice is a systematically collected, continuous source of data for the production of generalizable knowledge. And the knowledge that's produced is used to continually change and improve practice. So many activities like quality improvement, clinical analytics, comparative feedback look a whole lot like research, but occur under the heading of operations. And so, with that in mind, we get into questions about research versus QI work within health systems. And I think it's really important to recognize that this is on a spectrum. So if we think about the spectrum of clinical practice versus quality improvement versus research, we can think about clinical practice often involving adaptation and innovation at the individual patient level. QI involving systematic experiential learning in an operational context, so rapid feedback of data and trends used to make changes locally. And then research being theoretically distinct from clinical care and QI, and that it's designed to contribute to scientific knowledge. But when you kind of like mash this up and put it all together in real life, much of what we're doing in healthcare is simultaneously delivering the care patients need while capturing the experience of clinical practice in order to improve care for past, current, and future patients. And so to help navigate these the messy conceptual difficulties, some IRBs, like here at Penn, as you can see on this example to the left, have proactively created pathways to distinguish quality improvement from research. And this really highlights challenges regarding appropriate regulatory and oversight structures. We have ambiguity about oversight as this continuously ongoing problem and challenge. And in particular, it's problematic because individuals and institutions may have incentives to categorize implementation science as QI as opposed to research, because the QI designation may allow investigators to avoid the requirement for IRB review and other oversight. But that can lead to alterations in study design that reduce rigor without meaningfully reducing risk to participants. So for example, a skewing randomization, when randomized designs themselves don't necessarily increase risk. In addition, when studies are considered QI, there may not be the mechanism for independent oversight of risks and human subject protection issues. And so ideally, I say all this to highlight that we need updates to kind of our federal regulations ideally, but we're doing our best to operate within our current systems. And I do think that these structures and pathways help provide some distinctions in a very practical way. And so if you've established if you are in fact doing research and heading down that research path, the next question that comes up is, who are the research participants or the subjects? So what exactly is a human subject? The common rule is the main federal policy in the US that governs how research involving human subjects must be conducted ethically and legally. According to the regs, a human subject is a living individual about whom an investigator, whether that's a professional or a student conducting research, obtains information or biospecimens through intervention or interaction with an individual and uses, studies, or analyzes the information or biospecimens. So again, obtaining some kind of information through intervention or an interaction, and then obtains, uses, studies, analyzes, or generates identifiable private information or identifiable biospecimens, so that identifiable being key. And of note, if research meets criteria for an exemption category, like some surveys, interviews, public behavior observation, not all of these criteria may apply. When looking at human subjects, in traditional, again, contrasting here, in traditional biomedical research, individuals often serve as subjects with a focus on safety and individual outcomes. And so ethical review often focuses on individual rights. But for what we do in implementation research, our subjects can be individuals, groups, or entire healthcare systems. And so review boards then may need to assess the impact on communities, organizations, and health delivery systems. Many different people have roles in implementation research studies. I'm sure many of you who do implementation research know like our work is done in big teams and it impacts lots of people. And their interests may be affected as a result of the study intervention or data collection procedures. In clinical implementation studies, outcomes might be assessed among healthcare workers, patients, or other populations, all of whom may at times plausibly be considered to be a human subject according to federal regulations. And yet these different populations may have different relationships to the underlying study. And as a side note, this complicates even the choice of whether to describe individuals involved as participants or subjects. So subject is technically the regulatory term, and regulatory requirements apply to subjects for the purposes of IRB review, consent, risk-benefit assessment, and compliance. Participant is a term that can include broader groups, and in our work in implementation science, we might consider people to be participants in an ethical sense, even though they don't necessarily meet the regulatory definition of a human subject. We often share power, and people from health systems and communities jointly participate in all stages of the research process, which really challenges the traditional biomedical model of researchers as experts and subjects and participants as data sources. And so, again, coming back to design, we use lots of different design, and there's kind of lots of questions about who the research subjects might be in these examples. And we'll highlight some of these from the NHLBI workshop presentation by Dr. Jeremy Kahn, which was excellent, and you can find it at the link here. So, who's the subject of a retrospective observational study of metadata from the EHR to determine which ICU clinician characteristics are associated with the use of EVPs? There may not be one if it's de-identified data. What about an ethnographic study in which researchers observe ICU rounds to understand how collaborative behaviors might influence EVP uptake? Lots of different people involved in those observations. How about a prospective observational study using video-enabled ambient AI to spatially map provider interaction related to an EVP? Or a cluster RCT of 2 different clinician-targeted audit and feedback interventions designed to increase evidence uptake. So lots of questions related to the different designs that we use. So I'll share with you this framework from Nix and colleagues that came out in 2021. It's a guide for cluster randomized control trials, but I think it's very helpful and relevant across different study designs. This first step here, again, who are the research participants, is really key because it establishes moral standing and triggers considerations specific to research ethics. Here specifically, the need to apply the principle of respect for persons. The next step in this framework is to consider to what study elements are they exposed, the study intervention and or data collection. The study elements, so the specific activities, matter because this is where we consider where research adds incremental risk. So the additional risk created solely by the research beyond the risk of ordinary clinical care or daily life. And so really thinking what new risks does the research introduce compared to what would be happening anyway. And so there's lots of different potential risks of research, which include physical risks. So typically we don't really see this as a concern in implementation research, but it might be. Psychological risk, which is important, though perhaps, arguably overstated sometimes. Social and economic risks, loss of confidentiality, and then legal risks. I was prepping for my class a few weeks ago and found this really interesting paper from Manuel Tita. It's a new study, and I'll just flag it's a preprint. It's currently under peer review, so not published, available on Research Square, though. And I think it's fascinating and so relevant to our conversation. The authors highlight that risk is under theorized in implementation research. So, to dive into this a little bit, because implementation research studies often test interventions that are already established and safe, there's a prevailing view in the literature that the risks involved in our work are no more than minimal. Under the common rule, minimum risk or minimal risk is defined as harm no greater than that ordinarily encountered in daily life or during the performance of routine physical or psychological examinations or tests. However, recent work suggests that this definition may obscure subtler ethical risks inherent to routine implementation. And so again, implementation research is conducted in very dynamic and complex systems, such as healthcare organizations. We do work in schools, public health departments, where there's contextual variability, competing stakeholder interests, policy constraints that can introduce ethical challenges that aren't always visible or apparent in traditional efficacy trials. And again, this is where we depart from kind of the traditional biomedical paradigm. Studies have noted that even when an intervention itself is low risk, the strategies required to promote its adoption and implementation may disrupt workflows. They may expose structural inequities, or they may inadvertently burden staff or participants. And yet, our ethical guidelines and ethical review boards aren't always tailored to address these implementation research specific risk dimensions. Accurate minimal risk determinations are consequential because underestimating risks may gloss over harms, while overestimating could impose unnecessary review burdens, which then has implications down the line in terms of delaying uptake of interventions. So this particular qualitative study investigated how implementation researchers themselves conceptualize minimal risk. They explored participants' awareness of ethical considerations unique to implementation research, especially those not covered by current ethical standards, how they operationally define minimal risk and adverse events in their studies, and challenges they've faced regarding the ethical review process in implementation research trials. Some key themes were noted about the ambiguity of what constitutes usual care, kind of care that's happening, and the importance of considering, again, like who is at risk by the work. The distinction between risks posed by the intervention versus the implementation strategy, which I think is really interesting, right? We don't always think about our strategies necessarily as being sources of risks in and of themselves. And then the type of risks most likely to arise in implementation research and contexts. So I think we think traditionally about kind of clinical risks. We think about socio-behavioral risks, like those that may impact a professional, like a clinician that's being targeted by an implementation strategy. But we don't always talk about kind of operational or system level burdens that can come when you're implementing something new. So really interesting, and we'll look forward to seeing this in print. Ultimately, considering what really matters morally in protecting the rights and interests of patients and clinicians, we really need more thinking about what activities require and warrant ethical review, and to determine when patients and clinicians are at risk and in need of oversight protection. And I'll just kind of make the case that the labels of research, practice, QI, implementation science are poor proxies for what should be our central moral concerns. We really want to think about what are the activities and what are the incremental risks to which people are exposed. So with that, what about informed consent? So coming back to biomedical research versus implementation research. In biomedical research, consent's typically obtained from individual participants, like a little bit more straightforward. In implementation research, consent considerations extend to healthcare clinicians, administrators, patients. The scope includes the potential impact on systems and practices. And so we'll just highlight here in terms of highlighting the ethical purpose of informed consent. Again, it's based off of risk. Risk must be reasonable in relation to anticipated benefits. In terms of respect for persons from the Belmont Report, individuals should be allowed to weigh risk for themselves, and we operationalize respect for persons via the informed consent process by providing necessary information for a voluntary and informed decision. And so researchers must obtain informed consent from human research subjects unless a waiver or an alteration of consent is granted. And again, in terms of respect for persons, choices need to be sufficiently informed, voluntary, and considered. In informed consent procedures, researchers must provide potential participants with adequate information about the purpose of the study, study interventions, data collection procedures, potential benefits and risks, as well as alternatives to participation. I know you all are familiar with this, having probably written and gone through many informed consent forms. But there's also circumstances in which a waiver or alteration of consent requirement is appropriate and is ethical. Per the common rule, a waiver or alteration of informed consent may be applicable if the research involves no more than minimal risk. The research could not practically be carried out without the waiver. And so this must be a reasonable rationale. So situations in which the investigator has access to the prospective subject, but getting consent would make it impossible to actually conduct the study or would threaten the scientific validity of the research results. So an example, ethnography is baked into a trial to understand implementation processes. You're observing nurses in the operating room during handoffs, or studying a minimal risk behavioral intervention in which obtaining consent could introduce bias in terms of who opts into participating. The other requirement is that if the research involves identifiable private or identifiable biospecimens, the research could not practically be carried out without them in an identifiable format. The alteration or waiver will not adversely affect the rights and welfare of subjects. And then last, whenever appropriate, subjects will be provided with additional pertinent information after participation. So this means making the study results available to the individual subjects or to the broader community from which the subjects are drawn. So this could be in the form of newsletters or flyers in a doctor's office to inform those who were subjects. Alterations and waivers are justifiable if you meet these criteria here, but it's also important to recognize that these approaches are ethically distinct. Alterations of consent can encompass a broad range of options, from opt-out approaches to shortened consent forms that generally afford prospective participants an opportunity whether or not to enroll. Waiving consent means that there's no requirement for investigators to inform participants that they're in a research study. Participants will likely be unaware that they're in research and will have no opportunity to choose specifically participation. And so again, kind of back to this framework here, it's important to identify to which study element research subjects are exposed because we need to know what we're asking individuals to consent to or not to. So just to contrast these two examples here, audit and feedback that's provided to an entire nursing unit, so the whole unit, versus interviews to understand that experience of audit and feedback. It may be appropriate to have a waiver of consent for that feedback that's provided to the entire unit, but have traditional consent for interviews to understand the experiences of receiving that audit and feedback. So you can see those distinctions there. I'll point you to this recently published paper here, led by my Penn colleague, Dr. Emily Largent. The authors note that the number of pragmatic trials where consent is not obtained has been increasing over time. And one of the things that's highlighted is prospective consultation with members of the target study population that can address or at least mitigate some of the ethical challenges posed by appropriate waivers of informed consent, which we know is particularly appropriate or particularly important given the need to enhance trust in research. And so what this might look like might be open public forums, community advisory boards, presentations at civic organizations, or other avenues. And really thinking about the quality of that consultation rather than necessarily the quantity of it. So a really nice resource here for those that are interested in community consultation related to waivers or alterations and informed consent. And so briefly, just to touch on cluster RCTs, because I just think these are fascinating. So, and we use cluster trials quite a bit in this space. So why do cluster trials pose unique challenges? First here, the units of allocation, intervention, and outcome measurement can differ in a single trial. So an example of this is a cluster randomized trial of teaching a new hand washing technique to help avoid transmitting infection on hospital units. The units of allocation may be the hospital, the intervention may be delivered by healthcare professionals, and the data can be collected about or from patients, which again has all these implications for identifying who are the research participants, who needs informed consent procedures. Okay, second here, interventions are often administered at the cluster level, with the potential to directly or indirectly affect the interests of many people associated with the cluster. So an example of this is a community randomized trial of a mass media advertising campaign to promote smoking cessation. The intervention may potentially affect all community residents, but also people who are visiting or who might be driving through the study communities. Third, cluster level study interventions may be difficult or impossible for individuals to avoid, thereby precluding meaningful refusal. So back to the example of the mass media campaign, you can't avoid like driving by a big billboard. You're exposed to that intervention. Or for clinicians who do work in electronic health records, if there is a nudge that's being deployed, you cannot reasonably avoid, seeing the nudge or being nudged if this is the inner space in which you're working. Fourth, social groups or organizations are often units of allocation, but the understanding of the moral status of these groups and gatekeepers is very much incomplete. And last, vulnerable subgroups within clusters may be difficult to identify. And so I'll also highlight the Ottawa Statement for the ethics of cluster RCTs, which has explicit guidance. I've highlighted these 4 points here, which I think are particularly salient for us. We've talked about the first two, but I just want to briefly mention a bit on gatekeepers and protecting vulnerable participants. So a gatekeeper is an individual or a body who might be called upon to protect the group-based interests that are affected by enrollment in a cluster RCT. Importantly, just to distinguish, these are not proxy decision makers. Legitimate proxy consent requires that the proxy decision maker be well acquainted with the particular research participant's values and beliefs, making the proxy decision maker well suited to make decisions consistent with that potential participant's wishes or interests. This, again, is somebody that's thinking about the group-based interest. So again, we see that distinction from the traditional model focused on individuals. Here we're kind of expanding our lens to think about group-based interests. The legitimacy of a gatekeeper's authority depends on two things: their role within the organization, whether it endows them with the authority to make decisions on behalf of the cluster, like can they make the decision? And then also kind of in the converse, cluster members recognize the gatekeeper's authority. So an example here, you've got a school-based trial. The school principal may act as a gatekeeper to enroll a school in the trial after considering the impact on the school, including the availability of staff, the financial implications of participation, and the likelihood that teachers or students would be willing to participate. And so a key recommendation here is that gatekeeper permission, it's not a substitute for the informed consent of individual research participants. Consent may still be required unless, of course, there is a waiver or alteration. Notably, researchers should strive to identify situations in which the interests of different stakeholders within a cluster RCT may conflict. So for instance, the interests of an organization like a healthcare org or a school board may conflict with the interests of clusters within the organization, like physician practices or schools. or with the interests of individual cluster members like patients or students. There's rarely perfect alignment of interests. And because we know that implementation research is relational, multiple agendas may be at play. Importantly, the gatekeeper may not be in a position to consider the interests of all stakeholders. So it's really critical that we think through how to safeguard the interests of all individuals or groups who may be affected by the study recommendation. So a key recommendation here is our obligation to protect cluster interests through consultation. And again, this comes back to the importance of community input as we think about protecting and promoting group interests by really kind of critically examining and interrogating how we've designed our studies and how we've gotten impact into the potential interests of those who may be affected. And so kind of last kind of bucket to highlight today is protecting vulnerable subjects or participants. We can think about vulnerable research subjects as falling into 4 categories, 1 being children, 2 being incapable adults, so adults who are unable to provide informed consent, people who are at undue risk of harm as a result of study participation, and people who are in subordinate positions within social or organizational structures. As a nurse, I'm very interested in number 4. And so this may include health service staff, teachers, or other employees who might feel pressured to participate in a trial involving their institution. And so I just want to highlight again the presence of vulnerable participants within a cluster. That in and of itself doesn't preclude the use of a waiver of consent for all human research subjects in that cluster. I just want to really highlight that there's specific considerations here. And so when individual informed consent is required, and individuals who are involved may be able to choose their participation less able to choose participation freely. Research ethics committees and investigators should pay special attention to recruitment, privacy, and consent procedures. We really want to think about how to minimize the potential for coercive influence from organizational leaders. And as a reminder, the Belmont report defines coercion as when an overt threat of harm is intentionally presented by one person to another in order to obtain compliance. I will flag, as highlighted in this paper noted here, there are inconsistent views about coercion and undue inducement or undue influence held by IRB members, which can make these issues also difficult to navigate. And so as I wrap up this section, I just want to highlight fantastic work by one of our fearless Amethyst leaders, Dr. Megan Lane Fall, who has this paper here on ethical issues in implementation science, which is a qualitative interview study of clinicians who participated in the hat-trick study. And this study raises really, I think, fascinating and important questions for clinicians and implementation research. One is whether clinicians have a realistic ability to opt out of participation in group or unit level interventions. 2, whether an inability to opt out is a violation of clinicians' rights, or is this simply part of being a clinician who should be obligated to participate in research of some sort, of some capacity, particularly when it's no greater than minimal risk. And then what qualifies a particular gatekeeper to make judgments on behalf of clinicians who are themselves competent to provide or withhold their consent? These are really important questions for our field that we haven't resolved and are still addressing. So if these are things that you're interested in, there's lots of opportunity to write commentaries, to do empirical bioethics work. It's a wide open lane, and we need more people in it. So I see we've got, I think, 12 minutes left. What I'll do is I'll provide a kind of a high-level overview of this case study, and then I think we should have a couple of minutes for questions. So this is the Uplift R01, which is a study I lead. It's called Uniting Pediatric Nurses as Leaders in Firearm Injury Prevention, a hybrid trial. Just to note, I do work in implementation science, but I don't do work in maternal health. So please use this as an analog in terms of the content. My scholarship is in youth suicide prevention and firearm safety, but I think the lessons are applicable. So just as some background for those who don't work in this space, what shocks me every time I say this is that firearms are now the leading cause of death for American children. More kids are dying from guns than drowning, car accidents, and heart disease. 40% of American households with children have firearms. Firearms are ubiquitous in American society. And the presence of household firearms substantially increases the risk of suicide and unintentional injury for household members of all ages. So the gun in the house increases everybody's risk. For children and young adults, the risk is especially elevated based on how that gun is stored, particularly when firearms are stored unlocked and they're stored loaded. We also know that clinician counseling on secure storage is acceptable to parents, especially when it's informed by a non-judgmental harm reduction approach. And this is the work, this is the space in which I do much of my work. So in terms of what is my thing, in Greg Curran's language, the intervention or the thing of interest is called Safe Firearm. The setting is pediatric primary care. It consists of two core components: a discussion on secure firearm storage informed by a harm reduction approach, and the shared goal of keeping kids safe, plus free cable lock offers. The conversation is situated in the realm of anticipatory guidance. It's delivered by pediatricians or advanced practice providers during well child visits, and it's brief, often less than a minute to deliver. Notably, it's universal, so there's no screening. This is designed for all families regardless of firearm ownership, with no documentation of firearm ownership in the electronic health record, which was found to be important in addressing privacy concerns. So just briefly to lay out the aims, I'm just going to focus on aim 2 because that's relevant for our case study. We want to ask, after we do some adaptation work, to bring this intervention from pediatric primary care with pediatricians as implementers. We're scaling it out to the inpatient hospital setting with nurses leading implementation, with the goal of expanding the reach and impact of this evidence-based intervention. In aim 2, we're going to be addressing the question, is adapted safe firearm effective in improving secure firearm storage? This will be a parallel cluster randomized hybrid effectiveness implementation trial, so many words there, at 2 hospital campuses. It's a hybrid type 2 design, and with that, we're looking at effectiveness, but also implementation in aim 3. How does the strategy bundle impact adapted safe firearm implementation outcomes? And so because we've talked so much about design, I want to highlight design here. This is a parallel cluster randomized trial in which half of our units are allocated to usual continued care, and the other half are allocated to intervention and the implementation strategy bundle. Kind of breaking out all the different components of this. The intervention, again, is our adaptive firearm safety program, the universal brief counseling, the free lock offer for everybody. The intervention is delivered by nurses on units that are randomized intervention to eligible parents of kids admitted to units that are randomized to intervention. Our implementation strategy bundle is being developed right now. We anticipate it'll include training, an EHR prompt, and likely clinic level audit and feedback. The implementation strategy bundle is received by nurses and nursing units, and the data is collected by parent survey, child EHR, and nurse interviews. There's a lot. So we have to think, who are the participants? Where is their risk? And where in all of this do we need informed consent? So starting with the intervention itself, it's received by eligible parents admitted to units randomized to intervention. So again, back to that NICS framework, which I think is so critical for increasing the clarity and precision of our thinking. So who are parents? Who are participants? Here, parents are participants. They're directly intervened on. They're interacted on for purposes of collecting data, and the data is identifiable. They are research subjects here, research participants. To what activity, to what study element are they exposed? They're exposed to the safe firearm intervention. And for each element, is a waiver of consent appropriate? This intervention is no greater than minimal risk. And I apologize, I know this is hard to read. This is pulled directly from my IRB protocol, and I'm happy to share it with folks too who are thinking through these issues. So the activity is parent receipt of the intervention. Criteria 1 is minimal risk. Here we describe in our protocol that the intervention poses no greater than minimal risk. It's not novel to the institution, and it's already routinely being delivered to parents in primary care and other sites. We believe that the population of parents would not consider that their rights were violated. In terms of the practicality, this would threaten the completeness of generalizability of our study data if we were required to obtain informed consent, given anticipated non-response to requests for consent. It's not feasible from a staffing and resource perspective. And if consent was required for the adapted intervention receipt, nurse and patient characteristics would strongly dictate the likelihood of actually who got this. So it really impacts the scientific validity here. There's the criterion related to private information and post-notification. We're planning to make study results available to the broader community from which subjects were drawn. So this activity, parent receipt of the intervention, did meet criteria for a waiver of informed consent. And just to highlight here, what often I think gets tricky is when we think about clinicians. So the implementation strategy bundle is received by nurses. So when we think about who are research participants here, the nurse is the recipient of the implementation strategy bundle, directly intervened upon and targeted by that cluster level bundle of strategies. We're collecting data on delivery, and it's identifiable. So again, the study element is exposure to our implementation strategy bundle, which is our clinician-directed behavior change intervention. There's no greater than minimal risk. So would a waiver of consent be appropriate here? We thought it did meet criteria. So again, activity is participation in a pilot in RCT and receiving the implementation strategies among nurses. The strategies themselves are minimal risk. They don't differ from quality improvement activities that nurses routinely participate in as part of their employment. They're also free not to engage with this. They can use their clinical judgment and have that autonomy preservation. We believe that this does not impact rights, welfare, or general well-being. In terms of the practicality, which I think is important to note, is that when strategies are deployed at the cluster level, they're really hard to avoid. So again, you can't avoid an EHR-based nudge. It's really hard to avoid a training that's rolled out within a staff meeting. And then post-notification, nurses will know that they're participating in the trial and receiving the strategies, as this information will be kind of baked into the training of each unit. So a specific debriefing isn't necessary here. So I just want to flag as like a key kind of takeaway from this discussion is that waivers and alterations, while they can be and they are often ethically permissible, I'd argue that they increase our need for ethical awareness and ongoing consideration of nuanced risks and harms that may emerge. So even though I have a waiver of consent across these activities and participants, in no way does that decrease the need for ongoing scrutiny of the work and the importance of that attention to all different aspects of who's impacted and has moral status through the study activities. So I'll pause there. I think we have a couple minutes. I'm going to stop. I'll just say, here's my contact information. Please reach out. And thank you so much for having me today for part of this conversation.